So I will start talking to you about the question what to screen for and when. And maybe it's good then first to think about what exactly we mean by screening. When you are ill and you have a question to a doctor, you get diagnostic healthcare, and screening is an offer of healthcare, where you get a letter saying you are in a certain age category and now you are invited to join to a certain offer. Often it's a systematic offer to all newborns or to all pregnant women or to all women above a certain age to go for breast cancer screening. And it is an offer to healthy people. So if we balance the pros and cons, this means that we have to be rather strict in just inviting people for a screening if we are convinced that this has got more pros than cons. And when you think about the goal of screening, there is a very important distinction that I want to make first of all before speaking about when to screen. So the goal could be to avoid irreparable health damage, when you could live longer and healthier, so to say. And a completely different goal, which we cannot really is offering reproductive choice. So if it's related to whether you want to get pregnant or not, whether you want to get pregnant after embryo selection, whether you want to use prenatal diagnosis, and definitely in an ethical sense that this is a completely different field. The examples of the first goal are the screening for breast cancer, cervical cancer, colon cancer that exists in many countries. And when related to genetics, for instance, the newborn screening for PKU, which is a genetic disease that may lead to mental retardation, but if you give the diet, then the child will develop normal. The prenatal screening for rhesus-negative women, which is of course also a genetic problem, but there it is to avoid that the mother will form antibodies to the child. And another last example here is to screen family members for familial hypercholesterolemia. There, if you know at an early moment that you also have the genetic form of hypercholesterolemia, you may want to take medication and avoid smoking even more than all of us have to avoid smoking. And then examples of reproductive choice are prenatal screening for Down syndrome, which are programs in many countries, or spina bifida, especially the ultrasound screening. And preconception carrier screening for instance, thalassemia, which may be better known in the Mediterranean countries than in Northern European countries, or for sickle cell disease, cystic fibrosis, or Tay-Sachs, for instance, which is especially in people of Jewish descent. So then, when we think about this question, when to screen during life, first of all, we may think about after birth. If a child is born, in many European countries we have public health programs that screen for between 1 and 30 diseases in Europe. And when we did this study, there was one country missing, Albania, because they don't screen, so actually they should be between 0 and 30 diseases. And in all countries that screen, it is hypothyroidism that's in the program, but apart from that there are very big differences. For instance, Finland does not screen for PKU because in the population it doesn't occur. Only in migrants from, for instance, Sweden or Denmark it does occur. Or MCAT, which is not really a disease, but sensitivity. If you grow very fast, you may not have enough glucose in your blood, so you need frequent feeding. But once you know that, it's not really a disease. But if you don't know it, it may cause sudden death, for instance. So this definitely is a good public health screening program in many countries, and also under fast development because we get more and more predictive tests for the newborn. Well, if we then talk about a child that's just born, we may make the next step and consider what during pregnancy we may have prenatal tests. I already mentioned the screening for rhesus-negative women and whether they have a rhesus-positive child, which has the same blue color as the newborn screening because it's simply for health promotion. But in here also this more difficult ethical field of informed reproductive choice comes in. If you would screen for Down syndrome, that is to offer people also the choice to terminate pregnancy if they consider Down syndrome so serious that they would not accept the live birth of a child with Down syndrome. Even before pregnancy, you could already screen for carrier status of autosomal recessive disease. Carriers don't have any symptoms, so on average we are carrier of 2 to 3 recessive diseases, and that's not a problem, unless you marry somebody who also is a carrier for the same disease. And if your child then would inherit the same mutation for one disorder from both parents, he may get a severely form of it. And here again, the goal would be to give people the possibility to make a choice about getting pregnant or not, about using all kinds of techniques or not. And when speaking about the technologies that we have been listening to in the first hour, next generation sequencing is coming in here for the non-invasive clinical testing for Down syndrome, and also for this preconceptional testing. We see the development of tests where you could screen for more than 100 or more than 400 conditions. Also later in life you can screen for genetic conditions. For instance, if you screen for cholesterol simply during during labor, for instance, the very high cholesterols will point again to familial hypercholesterolemia. But you could also do DNA tests, and there in a systematic way you could invite all first-degree relatives, because they are in 50% risk of also having the same form of a genetic condition. And this is when to screen in lifetime, but you might also say when to screen is more related to the conditions. When is a test good? Is there a treatment available? And in this combination, if there's a good test available for a treatable condition where early diagnosis helps to prevent some of the symptoms, that could be the situation where you really want to build this into a public health program. And then for the part that is related to reproductive choice, you need parents and society to accept this test. So it should be an acceptable test. And then the technology, the last question, if technology makes it possible, that's why we changed this kind of thermodynamics, because many more is not possible than 10 years ago. Now we're sitting here to also reflect on the responsibilities of public health authorities, and then again for all those things related to health promotion, you could say we are obliged to protect children, and for instance then to organize access in all European countries to newborn screening possibilities that are good for all children. And also we could feel ourselves responsible to promote the health of all citizens of all ages. But in the field of reproductive choice, then again the responsibilities could be different. If we really take it serious that there should be an autonomous informed choice, then the element of informing people is perhaps the responsibility of health authorities to take care that parents are not coerced, so that they feel really free to take a decision on their own, to guarantee the quality of the information in the tests. So here the responsibilities are definitely different. We have been speaking already a bit about common disorders and the fact that genetic tests might not be that predictive for common disorders, but it's especially for genomic associations between SNPs, polymorphisms that are very frequent, and much of the tests that have been studied in the last 10 years were of that kind. But especially if we are moving to next-gen sequencing, we might also identify monogenic subtypes, much more rare conditions, especially in cardiogenetics and oncogenetics that is already ongoing, but we cannot predict all cardiological anomalies, but just few that are occurring at a low, at a young age, and where often there are interventions possible. So what are our responsibilities again in a broader sense? To discern types from reality, to stimulate the implementation of the few clinically useful tests, or in other words, as you will find in the document, the dedicated translational studies are needed. So if you see the word translational, that's defined very different by people. So some may say if it's translated from the mouse to the man, I consider that a translational study. But what I mean is, if we know something, let's try to implement it in public healthcare and see whether it works and learn from what is working well and what should be done better. And here again, the difficulty that we already discussed before the break also, to protect privacy on the one hand, and on the other hand, protect the possibilities for innovation and research. If we really put a lot of public funding in research and innovation, we also want to profit from that. That's definitely in a responsible way. And here the implication of whole genome sequencing data does require big data, because otherwise we will never understand what it means if we have a new value we see in sequencing data. But on the other hand, we need to do that in a responsible way. A word that was also quite clear in our report is the right to know, or perhaps the right not to know. And then, this is my last slide, I would want to argue that if there is a high predictive value with more possibilities to intervene and to live longer and healthier, then citizens increasingly have a right to know. And physicians also feel increasingly a duty to inform. So of course for many things we have a right not to know, but especially if there are good tests to predict and live longer and healthier, we should try to implement them. Thank you for your attention.